everyone. I am here to do the Shock and Sepsis Chapter 14 lecture for you. So let's begin. Make sure that you've already done your Davis Advantage pre-quiz before the lecture and read everything that you needed to read. Objectives for this lecture are to describe the pathophysiology, etiology, clinical manifestations, and direct and indirect causes of shock. Identify risk factors and prevention methods associated with shock. Illustrate the nursing process with providing competent care across the lifespan for people with shock, and then formulate priority nursing diagnoses appropriate for an individual with shock. More objectives: summarize therapies used by interdisciplinary teams in the collaborative care of an individual with shock. Plan evidence-based care for an individual with shock and his or her family in collaboration with other members of the healthcare team, and evaluate expected outcomes for an individual with shock. So what is shock? The official definition of shock is a clinical syndrome characterized by a systemic imbalance between oxygen supply and demand. There is an inadequate blood flow to organs and tissues, and this causes life-threatening cellular dysfunction. Usually, this is triggered by a sustained drop in our mean arterial pressure, or MAP, which we will go into detail in a couple of slides ahead. So other points to mention with shock is that you will have a decrease in blood flow that causes this inadequate oxygenation. So try to remember that when we're thinking about what's going on with the body in shock. So you have decreased blood flow, inadequate oxygenation, and then due to that, we have our ischemic organs and tissues that are dying off. So the end result of that being life-threatening cellular dysfunction. So really, all of the manifestations that we see from shock result from the body's attempt to try and maintain all of the vital organs. So the most important being the heart and the brain. As the body shuts down, it sort of prioritizes which organs are the most vital, with the least important organs being affected first, and then the most vital organs, such as the heart and brain, being affected last. So let's do an overview and review of some concepts. So we've got, really this is to help you kind of understand shock, and then we'll look at some of the concepts related to it. So cellular metabolism requires oxygen in and waste to be removed. So just try to think about how our internal plumbing works with the body. There's important concepts to understand when we're looking at shock, especially when it comes to cardiac output, oxygen delivery, oxygen consumption, and oxygen debt. So remember, cardiac output is the heart pump. Oxygen delivery is maintained and necessitated by blood vessels, their diameter, tone, and blood volume. Tissues need to be able to extract and use oxygen. If any one of these areas are disrupted, patients will develop shock. So remember these concepts. Body organs and tissues require a regular, consistent supply of oxygen and removal of metabolic waste. Sufficient cardiac output is required. And again, what does sufficient cardiac output mean? What does it mean? So it's an uncompromised vascular system that is able to dilate and constrict, provide sufficient blood volume with healthy tissues, being able to extract and use the oxygen delivered by the capillaries. All right, so let's look at pathophysiology and etiology. So we just mentioned cardiac output is the heart pump. Cardiac output is calculated, and it's a calculated function of stroke volume multiplied by the heart rate. So what's stroke volume, which is SV? It's the amount of blood pumped into the aorta with each contraction of the left ventricle. Cardiac output, or CO, is the amount of blood pumped by the left ventricle into the aorta per minute. Cardiac output equals stroke volume times heart rate. Try to remember that. Cardiac output equals stroke volume times heart rate. So what's our mean arterial pressure? We see this often in practice. So it's not mentioned much in the book, but you will see it when you're in clinical, and you will see it quite often as a nurse. So the MAP, mean arterial pressure, is defined as the average pressure in the arteries during one cardiac cycle. So it's actually considered a better indicator of perfusion to vital organs than the systolic blood pressure. So a true MAP, though, can only be measured hemodynamically via a Swan-Ganz catheter, which is also called the pulmonary artery catheter, or PAC, and we'll go into that a little bit. But realize that when you see physicians putting in orders for us to monitor the MAP, that's why it's a better indicator of perfusion to vital organs. So some formulas to calculate MAP. So double the diastolic blood pressure and add the sum, so whatever that diastolic blood pressure is double, add that to the systolic blood pressure, then you divide by 3. Or you can calculate the pulse pressure, which you subtract the diastolic blood pressure from the systolic blood pressure, and divide by 3, then you add the diastolic blood pressure. So just some formulas to look at. Normal MAP is greater than 65 millimeters of mercury. It's good to know that. Normal MAP is greater than 65 millimeters of mercury. Systemic vascular resistance, or SVR. Some of these acronyms you will see in lectures, so try to remember what they are. SVR, so it refers to the resistance to blood flow by all of the systemic vasculature minus the pulmonary vasculature. So systemic vasculature is throughout the body, minus the pulmonary vasculature. It increases as vessels constrict. So think about when epi is given, vessels constrict, and it decreases when vessels dilate, like septic shock. So if there's any change in the diameter, elasticity, or number of vessels, it can influence our systemic vascular resistance. So systemic vascular resistance calculation would be SVR equals your MAP, mean arterial pressure, minus your CVP, which we'll go into next, which is central venous pressure, divided by your cardiac output. Central venous pressure is the amount of blood pumped out by the heart per minute. Normal amount is 2 to 8 liters a minute. It's used to evaluate fluid volume status. You have a low number, then you have a fluid deficit. If you have a high number, then you're in fluid overload. It's used mainly for CHF patients in the ICU. And then try to remember with contractility. So when you're thinking about cardiac output, remember a poor squeeze of the heart results in a decreased stroke volume and decreased cardiac output, and vice versa. All right, cardiac output. So let's do a review of some basic hemodynamics. So the heart rate is affected by stimulus from our autonomic nervous system. Remember, it's sympathetic, adrenergic, or parasympathetic cholinergic. So remember, we have our stress hormones from the adrenal medulla, which gives us epi and norepi. So that can adjust the heart rate up or down. Changes in blood pressure are sensed by baroreceptors, which can also affect the heart rate. Stroke volume is the amount of blood ejected with each ventricular contraction. It is influenced by 3 variables: preload, afterload, and contractility. So preload is the amount of blood in the ventricles at the end of diastole. It reflects a patient's fluid volume status. An increase in preload increases cardiac output. A decrease in preload decreases cardiac output. The term filling pressures refers to the values obtained to measure preload. Afterload. So this is the amount of resistance for blood to flow, or the amount of pressure the ventricle must overcome to eject its contents. So this is also called systemic vascular resistance, or SVR. We just talked about that. Increasing afterload makes it harder for the heart to eject blood into our circulation. Vasodilation decreases afterload, whereas vasoconstriction, remember sympathetic nervous system stimulation, so vasoconstriction increases it. In order to increase perfusion, which is impaired with shock, you need to improve this portion of these hemodynamics, which are impaired. Increasing cardiac output is the key. Contractility, that is the force of the mechanical contraction. If you have poor contractility, you'll have a decrease in stroke volume, and then of course you'll have the decrease in cardiac output. So let's continue talking a little bit about cardiac output. Let me bring up the slide here for you. Okay, so oxygen delivery, or DO2. So that is the amount of oxygen delivered to tissues. It's assessed through the evaluation of cardiac output and arterial oxygen content. Oxygen consumption, or VO2, is the amount of oxygen extracted from blood at the tissue level. And then you also have a mixed venous oxygen saturation, or your SVO2. So SVO2 reflects the amount of oxygen in the blood that is returned to the right heart. It's a measurement of the oxygenation saturation from mixed venous blood, SVO2, in the pulmonary artery. Normal SVO2 levels are 60 to 75% and are measured via a pulmonary artery catheter. Remember that Swan-Ganz catheter, PAC. So when this level falls below normal, tissues are extracting more oxygen than normal. Levels fall when supply is less than demand or use, resulting in decreased oxygen delivery, and it'll also give us our information on oxygen debt. The longer there is an imbalance between the cellular oxygen supply and demand, the larger the oxygen debt becomes. So you have more supply and demand, you have higher oxygen debt. SpO2 is a reflection of pulmonary status. So that's why we put in their pulse ox. So it's not necessarily reflective of the adequacy of treatment for cardiac output and shock. If a patient doesn't have a pulmonary artery catheter, you can use the MAP for measurements as tissue perfusion assessment, or mean arterial pressure. It's definitely not as accurate as a measurement that you would get with the pulmonary artery catheter. There are also some medication drips where you will titrate the drug based on specific parameters with MAP measurements. All right, connection check. So the nurse understands that which of the following increases as the delivery of oxygen, DO2, to the tissue falls below the tissue's requirements. Select all that apply. Why don't you pause here, take a few minutes to answer it, and then restart it, and then you'll have your answer as soon as you restart it. All right, so the answers are A and B. So shock equals oxygen consumption or demand, which is VO2, which is greater than the supply available, or DO2, delivered oxygen. SVO2, again, is how much oxygenated blood returns to the heart, which would decrease as with the PaO2. Decreased preload is a cause of decreased DO2, or oxygen delivery. oxygen consumption, or VO2, would be increased by attempting to meet the needs as oxygen delivery is less. So this, again, will result in that increased oxygen debt. Okay, case study. I can go through this too. So Mike Adams is admitted to the ED. He complains of shortness of breath, has a history of hypertension and well-controlled diabetes. Vital signs: a temperature of 101.9, 38.83 Celsius. Pulse is 120, respiratory rate's 20. Blood pressure is 90 over 54. They did do a chest x-ray that shows pneumonia. He's Ehlers-Oriented times 4. Complains of feeling dizziness with changing positions. So there we've got some orders from the physician. We have IV of 0.9% normal saline at 125 an hour. We got some labs to draw: CBC, basic metabolic panel, and blood cultures. We're going to put oxygen on him at 2 liters a minute via nasal cannula. And then we're also going to start an antibiotic, cefotaxime, 2 grams IV Q8 hours. So in what order would you perform these interventions? How are blood cultures drawn? Is the oxygen order typical of what you've seen in clinical? So again, pause the lecture, go ahead and answer these questions, and then as soon as you hit start, you'll get your answers. Okay, so for the answers, order of intervention: oxygen first. You're going to do your IV start with, typically labs are drawn at the same time. Then you'll start your normal saline and your antibiotic. How are blood cultures drawn? So remember, you get 2 different sites. Chlorhexidine is usually wiped on the vials on the site. It's time drawing. You usually have to wait 30 seconds or so. You'll have 2 bottles, so anaerobic culture bottles. And then 2, it does depend on the facility. A lot of times they will want you to draw the blood cultures, though, before the antibiotics are started. Why would you think they would want to do that? Think about it. And then 2, is the oxygen order typical of what you've seen in clinical? Yes and no. I mean, parameters are needed, and we need an order, of course, for continuous SpO2 monitoring and to be able to apply oxygen. So most likely we would need more than 2 liters. So it does depend on the patient. Okay, stages of shock. So just remember, all of the stages of shock are going to be the same for all types. So make sure you look at table 14.2 in your book. So it's on pages 259. So the 4 stages are initial, compensatory, progressive, and refractory. Without treatment, patients will progress to the next stage. Early identification and treatment is the key to improving patient outcomes. Remember that early identification and treatment is so important with these patients. All right, initial stage. So the system response includes decreased oxygen delivery to the tissue. So remember this, in the initial stage, the system response includes decreased oxygen delivery to the tissues. It's the very first thing that happens. So the MAP might drop. You'll see that, a drop of 5 to 10 millimeters of mercury, and then your circulating volume, which is a decrease in about 500 mLs. It's really not enough to cause serious effects, and it can be really hard to tell these sort of subtle changes. You will see, though, decreased oxygen. You might see a little hypoxia due to that decreased delivery of oxygen to the tissues and cells. Signs of a patient in the initial stage, again, might be subtle, but there is some cellular damage. It is a little limited. So really, kind of the only way to get an understanding to see if there's decreased cardiac output in the initial stage is if the doctor decided to do invasive monitoring, which would be not likely at this stage. They're probably not unstable enough to do that. So the compensatory stage, there's compensation mechanisms that are initiated more than the initial stage. So you'll find neuroendocrine and chemical compensation. So the compensatory stage is characterized by the initiation of compensatory mechanisms. So try to remember that. So compensatory stage is compensatory mechanisms initiated. So these mechanisms are an effort by your bodies to maintain perfusion, adequate volume, cardiac output, and blood flow to the tissues. So what's neural compensation? This is characterized by the detection of hypotension by the baroreceptors in the carotid sinus and aortic arch that results in the stimulation of the sympathetic nervous system and the release of the catecholamines, epinephrine and norepinephrine from the adrenal medulla. So this cascade of events that happens. Your heart rate and contractility increase, improving cardiac output. You have systemic vasoconstriction, which will occur, resulting in increased blood pressure and redistribution of blood flow from non-essential organ systems to vital organ systems. Endocrine compensation, those are our hormonal mechanisms that exert control over blood pressure. This includes angiotensin II, epinephrine, norepinephrine, aldosterone, and our antidiuretic hormone, ADH. Angiotensin II is created in response to that low blood pressure and is an end product of a series of events affecting the heart rate and contractility. And chemical compensation is produced through the reaction of chemoreceptors in the aorta and carotid arteries that are stimulated by low oxygen levels. Tachypnea or hyperventilation occurs in an effort to increase circulating oxygen levels. So there's a respiratory alkalosis that results, and it causes that constriction of carotid arteries. So look at page 258 too, to look at sort of the respiratory alkalosis that occurs. Okay, so more about the compensatory stage. So you will have vasoconstriction, increased sodium and water reabsorption. You'll have shunting of the blood away from non-essential organs. You'll also get increased glucose production. So try to remember these things. So you'll have shunting of the blood away from your non-essential organs to vital. You'll have increased sodium and water reabsorption, vasoconstriction, and increased glucose production. You'll notice a continued decrease of the patient's MAP. Shifts will occur with interstitial fluid moving into capillaries, so you will find decreased skin turgor and a prolonged capillary refill. So this maintains perfusion, including the blood pressure, for a short period of time. See how the body is trying to compensate. It can maintain it for a short period of time, but it cannot last. Early recognition of problems and treatments are a must. So here's a diagram and illustration of a patient's response in the compensatory stage. So you read through those, look at some of the symptoms. Patients will often show restlessness and complain of feeling lightheaded, possibly display signs and symptoms of confusion. You'll notice an increased heart rate. That's there to help maintain the patient's blood pressure. The brain sends signals to the heart to increase the heart rate. So the brain sends signals to the heart to increase the heart rate. Tachypnea and respiratory alkalosis will develop. You'll have oliguria, urine output will be decreased. Hyperglycemia will be present to help with energy use. You'll hear hypoactive bowel sounds. Weak pulses will be present along with the extremities becoming cool. Having moist skin and skin turgor will be poor. You'll also might notice some bleeding into the pelvis, which is listed on here, and that's due to some capillary endothelial damage. So that's it for the compensatory stage. Moving on to the progressive stage. So in this stage, there's an extensive shunting of blood away from non-essential organs, and there will be failure of the sodium-potassium pump. This stage occurs after a sustained decrease in MAP of 20 millimeters of mercury or more, and you'll have fluid loss of 35 to 50%, which is about 2,000 milliliters. Compensatory mechanisms are no longer able to keep up in this stage. Although they continue to remain active, they're really trying hard, but they cannot maintain tissue perfusion in vital organs. Cells in the heart and brain are hypoxic, and other body cells become ischemic and anoxic. Acidosis and hyperkalemia need rapid treatment or death will occur. Cells switch from aerobic to anaerobic, which is, remember, lactic acid, which is a byproduct of anaerobic metabolism, lowering pH, increasing acidity. So serum lactate levels are drawn. We'll have laboratory draw serum lactate levels. So what that shows us, what those serum lactate levels show us in the blood, is it's associated with an increased mortality. Anything greater than 4 mmol/liters, millimeters, I'm not sure what that stands for, but anything greater than 4 is associated with an increase in mortality. Really, that's telling us the capillaries become more permeable and cause fluid shift. The heart rate and vasoconstriction slightly increase, however, perfusion is diminished. Signs and symptoms may be severe hypotension, pallor, tachycardia, irregular heart rhythm, peripheral edema, cool and clammy extremities, and altered LOC. Main thing is, with progressive stage, is you must fix this quickly. So here's another illustration of the patient's response in the progressive stage. Clinical manifestations include lethargy or coma. The patient's mental state deteriorates because the brain, of course, is getting less oxygen. Blood pressure drops, causing hypotension. The heart rate will be increasing along with respirations increasing. So heart rate increases, respirations increase. You might have dysrhythmias due to the electrolyte imbalances. So you'll have hyperkalemia, elevated potassium levels. Anuria will be present, or less than 100 mils of urine output per day. There will be third spacing edema present because you have water that begins to flow out of the capillaries into the cells of the body, causing them to swell. Absent bowel sounds, severe metabolic acidosis, respiratory acidosis. You'll have cold extremities and weak, ready, or absent pulses. And in this stage, you'll have hypoglycemia, so low blood sugar. Okay. So now we'll talk about the refractory stage. So in this stage, there's inefficient anaerobic metabolism and extreme tissue hypoxia. Tissue anoxia becomes generalized. Cellular death is widespread, and there's no treatment to reverse the damage. This is the end stage. Even if the MAP is restored at this stage, there's too much cellular damage that has occurred to maintain life, and shock is not reversible at this stage. The patient will be in a coma. They'll have severe hypotension, severe metabolic and respiratory acidosis. They'll have hepatic failure, renal failure, and peripheral tissue ischemia and necrosis. The patient will not survive this. There's no treatment available to reverse the damage. So let's do a connection check. The nurse monitors for which manifestations during compensatory shock. Remember, they're compensating. Blood pressure is normal limits. They have oliguria. They have cold extremities and hypoglycemia. Are they weak pulses and hypoventilation? Or are they hypotension and tachycardia? The answer is A. So, manifestations for compensatory shock include restlessness, confusion, increased heart rate, tachypnea, respiratory alkalosis, oliguria, hyperglycemia, not hypo, decreased bowel sounds, weak pulses, and cool, not cold. Moist skin compensatory mechanisms also temporarily maintain the normal blood pressure. Cold extremities and hypotension are associated with progressive shock. So how are we going to assess and monitor these patients? So priority number one is to identify that shock is present. Recognition is not always obvious. You might have something else going on like slow internal bleeding, sort of a non-identifiable infection. But meticulous assessments are very essential. Pay close attention to any subtle changes with your patients. Priority two is to evaluate the progression. So you want to complete this by frequent physical assessments. Hemodynamic monitoring is essential too. So you want to monitor and track patient trends. So this is a really good example of when we say monitor your patient trends, this is why. So you want to include really close monitoring of the patient's blood pressure, cardiac output, and the variables that affect cardiac output. So monitor that map. This will provide valuable insights into the present stages or resolution of shock. And then we also want to monitor our laboratory data. So this table is another resource for you to review, which represents how each body system changes and what you'll see among patients in compensatory and progressive shock stages. So make sure you review this. Use this to study. All right, so we're going to look into some of the central lines that we've talked about a little bit. So first we're going to start with the arterial line, which you'll see these in critical care units. So having an arterial line allows for continuous blood pressure monitoring and easy access for ABG samples. So it's very important to have this for our shock patients. It's never used for infusing fluids or medications, never. You want to protect that site since it's an artery. There's definitely an increased risk of bleeding or dislodging. And then most transducers used to provide invasive arterial blood pressure monitoring require a pressurized supply of saline. So you'll see in that image, there's a pressure bag. They squeeze the pressure bag up so that the saline is providing a continuous flow. What that does is it also ensures that the transducer functions appropriately and it prevents the system from clotting. So it's usually just a smaller bag of normal saline, about 500 ml. They'll squeeze it so there's enough pressure to just have a nice slow drip of saline through. Pulmonary artery catheter. So this you might see as well. It's inserted. It's actually a flexible balloon tipped catheter that's guided through the right side of the heart and into the pulmonary artery. This, of course, is done by physicians. Having the pulmonary artery catheter present allows for us to obtain detailed information about cardiac output and the variables that affect it, such as our preload, which is also called our filling pressures, and then also we'll be able to monitor our afterload and contractility. So again, the pulmonary artery, we have it inserted through the right atrium into the pulmonary artery, which you can see in the image. It has two ports, a proximal port for the right atrium and a distal port for the pulmonary artery. The proximal port of the right atrium provides the measurements for CVP. Remember our central venous pressure, which is a reflection of the right heart's preload, tells us if they're in fluid overload or if they're in fluid deprivation. And then cardiac output can be measured by thermodilution too, with that proximal port. The distal port is used for pulmonary artery measurements, including pulmonary artery pressures, which are especially used with monitoring pulmonary hypertension patients. With this support, you may also measure the left heart preload, and we're able to draw an SvO2 sample, which is a mixed venous oxygen saturation level. So this sample of blood obtained can prove information on oxygen extraction throughout the entire body. It's very specific. And then also through the distal port, the nurse can monitor the PaO2, which is the pulmonary artery occlusive pressure, or the PaWP, pulmonary artery wedge pressure. So these both will provide left heart preload data, or the amount of the blood in the left ventricle at the end of diastole. These are really nice to have when you have a sick patient. So a CVC, or central venous catheter, it's a catheter threaded through the superior vena cava with the distal port resting in the superior vena cava immediately above the junction with the right atrium. So this is another, the central venous catheter will be put in by a physician. So the CVC has a distal port, which can be used for monitoring our CVP, central venous pressure, if a pulmonary artery catheter isn't in place. The CVP is used as an estimate of volume returning to the right heart or right heart preload. A decreased CVP reading may be indicative of a low volume state, such as hypovolemic shock. An elevated CVP may indicate increased volume that may occur with cardiogenic shock, or CHF. So our SvO2, central venous oxygenation saturation, can also be monitored and closely correlates with our SvO2. It provides information primarily on oxygen extraction in the brain and upper body. So remember, our SvO2 is a reflection of oxygen consumption at the tissue level. All right, laboratory analysis. So table 14.4 on page 264 of your book is a great tool for looking at lab tests for the evaluation of shock, so please review that. ABGs, we're going to look at that for sure. In early shock, the pH, which would reflect alkalosis. Remember, in late shock, the pH is decreased, reflecting acidosis or metabolic acidosis. A decreased PaO2, the partial pressure of oxygen in arterial blood, is a value less than 60. So a decreased PaO2 is a value less than 60. That indicates the development of complications such as acute respiratory distress syndrome, or ARDS. So any value less than 60 on a PaO2 is bad. Base deficit. So its sustained negative levels reflect the severity of shock. So if you're looking at this base deficit and you have sustained negative levels, then we know that the severity of shock is worsening. So arterial base deficit shows a tissue injury severity because it's correlated with arterial lactate concentration. Our SvO2, which is our mixed venous oxygen saturation, if less than 60%, indicates increased oxygen extraction at the tissue level, indicating decreased oxygen delivery. So it's important to note SvO2 is a reflection of oxygen consumption at the tissue level. Make sure you know that. Lactate levels. So anything greater than 2 is abnormal. Remember, increased values indicate the presence of anaerobic metabolism. And then the higher the number goes, the worse the state is. Base excess estimates the extent of acidosis at the tissue level. Lactate and base excess are used as estimates for the extent of acidosis at the tissue level. So both are good indicators of the severity of shock. They'll look at lactate and base excess. All right, let's do another connection check. So the nurse understands that the following are the best parameters for evaluating the severity of the shock state. Select all that apply. So I'll give you a minute to pause and then read through. All right, your answers are A, B, and C. So rationale, SVO2 is a reflection of oxygen consumption at the tissue level. Lactate and base excess estimates the extent of acidosis at the tissue level. Evidence has shown all three are good indicators of the severity of shock. Glucose levels may elevate as part of the compensatory process, but they don't directly reflect the severity. And a low PaO2 can indicate ARDS, so it's not shock in general. Here's your answer. So now we're going to look at the types of shock. We talked about this earlier with looking at the cardiovascular system as plumbing. So try to think of it this way. The heart's the water pump, all of our vessels in our body are the pipes, and our blood is the water. So in hypovolemic shock, we don't have enough water in the tank. Cardiogenic shock, the pump is malfunctioning. Think of like CHF. And then obstructive is a clogged pump, clogged valve, you have tamponade or tension pneumo. And then distributive means the pipes are expanded, so you have sepsis. Might be a CNS injury or neurogenic or anaphylactic or an allergy. So let's do another connection check. Which patient is at risk of developing hypovolemic shock? Patient with severe valvular disease, a surgical patient with spinal anesthesia, a patient with severe GI distress like nausea vomiting, or a patient with a large pneumothorax status post a motor vehicle crash. I'll take a second to answer. And then our answer is hypovolemic shock can result from fluid loss associated with excessive vomiting or diarrhea. So that person with GI disorder. A large pneumothorax may progress to a tension pneumo. Both tension pneumo and valvular disease cause obstructive shock. And then complications associated with spinal anesthesia may cause neurogenic shock. So we'll first talk about hypovolemic shock, which is a profound loss of intravascular volume, including hemorrhage, burns, dehydration, diarrhea, and vomiting. Manifestations are dependent upon the stage and is directly related to compensatory mechanisms. So remember your stages. You have initial, compensatory, progressive, and refractory. Hemodynamics include decreased cardiac output, increased SVR or afterload, RA pressure, your CVP, and your PaOP are decreased. So for medical management, the absolute highest priority is always going to be our airway. So you might need to do 100% non-rebreather. They may need to be mechanically ventilated. And then with these patients too, if it is, say, nutrition related, deficit, then you might start a slow progression of parenteral or enteral feeding. You want to kind of go slow. Also, fluid resuscitation is key, and it really depends on the cause of the hypovolemia. You'll choose, of course, a different fluid for volume expansion. I do want you to read the evidence-based practice table on page 265. Let's look into our fluids here, IV fluids. So we've got isotonic and hypotonic solutions, which both increase fluid volume in your intravascular and interstitial spaces, while hypertonic solutions pull fluid into the vascular space. That's like your 7.5% saline. So hypertonic solutions pull fluid into the vascular space to promote excretion. And then our crystalloids increase fluid volume in the intravascular and interstitial spaces. Colloids do not diffuse through capillary walls. They remain in the vascular system and increase the osmotic pressure of the blood, causing fluid to move into the vascular space, which helps to expand volume. So our colloids are sort of also hypertonic. They're Hespan, which is 6% head of starch, or you'll see albumin quite a bit in practice, or dextran. It's also important to continue fluid resuscitation until that oxygen debt that has accumulated has been repaid. This can be indicated by clinical signs such as the blood pressure stabilizing. You might also have strong peripheral pulses, warm extremities, adequate urine output. They might have decreased signs of level of consciousness, or improvement of their decreased LOC. You'll notice lowering of the lactate levels and base deficit levels, and they might even return to normal limits. Another thing to mention too with hypovolemic shock is we might give them blood transfusions, especially if it's someone who's bleeding. So what are our blood transfusion? PRBCs are red blood cells, FFP, fresh fluid and plasma. We might also give some platelets. Usually it's a combination if you have someone with severe blood loss. Your goal is a hematocrit of 30 to 50%. Another thing you want to watch for is hypocalcemia with massive transfusions due to the preservative that they use. And then the hemoglobin, you want 12.5 to 14.5. So medical management also includes identifying and controlling any further blood loss. We want to do some diagnostic testing. We'll look at CT and x-rays. We'll do our fluid resuscitation with blood products. Usually it's 1 to 1 to 1. We want to know where is it coming from, what's going on, where's blood loss coming from. And then also we want to make sure that some fluid resuscitation strategies for trauma patients suffering from large amounts of blood loss. We want to make sure that we're doing a balanced response. So we might do crystalloids, minimizing crystalloids. So blood loss would call for a balanced response of minimized crystalloids. So this includes our 1 to 1 to 1 ratio. So that would be our PRBCs, FFP, and platelets. So you want to do that 1 to 1 to 1 ratio. Also, we might do surgery. We might stabilize fractures, or if it's like GI related, we might try to give some medications to control nausea and vomiting. So nursing management. With your assessments, make sure you monitor the LOC, your level of consciousness, vital signs, their hemodynamics, urine output, skin color, and temperature. You want to monitor all those labs, your ABGs with base deficit, lactate levels, SVO2 or SCVO2, your hemoglobin and hematocrit, and your CMP. Make sure we supply oxygen to our patients who need it. Might use a non-rebreather or an ET tube. We might intubate them. Usually we always try to have at least 2 large bore IVs for fluid replacement. 2 is essential. And then 2, if it's blood products, you want to make sure that it's a certain size gauge. So we usually want it to be an 18 gauge or 20 gauge. That's might be facility dependent too, so make sure that you review that policy. I also want you to look at the safety alert about permissive hypotension on page 266. So make sure you read that. It talks about the strategy that they use to reduce post-resuscitation mortality and morbidity from decreased coagulopathy. So these patients responded with needing less fluid and blood administration, It also is thought to increase the blood pressure that may dislodge a newly formed clot, increasing the possibility of bleeding. So it's just interesting to learn about what this permissive hypotension would do for these types of patients. So some teaching we want to instruct regarding the cause of the hypovolemia to prevent recurrence if it's something that's preventable. Make sure our assessments are thorough, monitor neurological status, vital signs, hemodynamic readings, urine output, skin color, and temperature. Monitor our lab work, monitor our trends, evaluate care outcomes. So our outcome really is just based on restoring hemodynamic stability with rapid interventions. So we really want them to improve quickly. Connection check. So which hemodynamic parameters are consistent with hypovolemic shock? A decreased cardiac output, decreased SVR, decreased RA pressure, decreased CO, increased SVR, decreased RA pressure, decreased CO, increased SVR, increased RA pressure, or decreased CO, decreased SVR, increased RA pressure. So RA is right atrial pressure. All right, I'll give you a minute or two to answer that. And then the answer is B, hypovolemic shock. So it results in the decreased cardiac output due to the decreased filling pressures. You have systemic vascular resistance increasing as a compensatory mechanism. Right atrial pressure is decreased as the amount of fluid returning to the heart is decreased. So now we'll move into cardiogenic shock. So this develops from a severe impairment in ventricular contractility. So what would cause that? An MI or anything that would cause decreased myocardial contractions. Manifestations are usually directly related to left and right-sided heart failure. You'll have decreased cardiac output, hypotension. You might have increased filling volumes. Cyanosis is usually profound with pulmonary edema, increasing vasoconstriction and fluid retention, and increasing myocardial workload. Cardiogenic shock has a very high mortality rate of 50%. The rate is even higher in patients older than 75, and then it is lower in younger patients. Risk factors include any disorder that results in the acute deterioration of myocardial mechanical contract. So manifestations are similar to our acute MI symptoms, which would be chest pain, diaphoresis, nausea, vomiting. So MI against myocardial infarction. Other assessment findings correlate with the specific stage of shock the patient is currently in, whether it's initial, compensatory, progressive, or refractory. Hemodynamic, so these patients will have increased filling pressures. Both right and left preloads are increased because of the impaired pumping ability of the heart, but cardiac output is low. As a result of compensation for low cardiac output, vasoconstriction occurs, increasing our systemic vascular resistance, and our SpO2 decreases, along with an increased systemic vascular resistance. So some diagnostics that we'll do for cardiogenic shock, we'll definitely do a 12-lead EKG. Should be one of the initial diagnostic tests to rule out an MI as the cause of shock. We'll do some cardiac enzyme lab work. So might be our troponin levels, and then a chest x-ray to rule out any other causes, including hypotension, any other types of shock maybe that might be present. And then also we might see if there's some pulmonary edema. Treatment priorities are always going to be the airway. So we might do 100% non-rebreather. They might even need mechanical ventilation. So improving or enhancing oxygenation may help decrease myocardial workload increase myocardial oxygen supply, and help preserve myocardial tissue. Then initiating drug therapy to increase blood pressure and cardiac output. So remember, oxygenation first. We might even administer some vasoactive or vasoconstricting, vasopressor medications to help sustain blood pressure and help maintain that adequate mean arterial pressure for a MAP. Look at table 14.5 on page 268, which talks about medications commonly used to treat shock states. Norepinephrine or Levophed. This is a vasopressor. It's pretty common. It produces vasoconstriction and myocardial stimulation, which may be required after adequate fluid replacement in the treatment of severe hypotension and shock. You want to treat that low volume first, or hypovolemia first. This drug has an extravasation hazard and it may cause tachyarrhythmias. Now, there's always consequences to some of these drugs too that can happen. Dopamine, it's inotropic, vasopressor, adrenergic, that works to increase cardiac output, increases blood pressure, and improves renal blood flow. This one too you want to watch for extravasation. This one also can cause tachyarrhythmias, and then the effects are usually dose dependent. Dobutamine is an inotropic support, can be used for heart failure. It does help by increasing contractility and cardiac output without increasing the heart rate. It may cause hypotension and tachyarrhythmias. Nitroglycerin, anti-anginal. Nitrate, we've heard of that. It's used, we got to use this one with caution. It's typically used to treat acute MI, relieves and prevents anginal attacks, and increases cardiac output. Also reduces blood pressure. This one may cause tachycardia, a headache, and hypotension. Tolerance may also develop. So if they're on it for a long time, they might need to have the drug titrated up. And then nitroprusside or Nitropress. This is an antihypertensive. It's a vasodilator used for cardiogenic shock, hypertensive crisis, rapid lowering of blood pressure. It decreases the cardiac preload and afterload. May cause cyanide toxicity. You do want to observe for changes in mental status, clinical deterioration, and lactic acidosis. Excuse me. So if medications are ineffective to improve cardiac output, we might use an intra-aortic balloon pump, or IABP, or a vascular access device, VAD. So look at figure 14.5 on page 270. So the intra-aortic balloon pump increases myocardial oxygen supply and decreases myocardial oxygen demand. There is a balloon at the tip of the catheter that is timed to inflate at the start of diastole and deflate just before systole. The ventricular assist device, ventricular assist device is surgically inserted. It's a mechanical pump that's implanted and assists the pumping of the left ventricle and decreases the workload of the heart. So it's a ventricular assist device, or VAD. For medical management of these patients, we want to do diagnostics or EKG, some lab work or troponin, chest x-rays. We want to treat the underlying cause with revascularization. Number one cause is usually an MI. We want to be a little cautious, limiting use of IV fluids. Slowly begin our parenteral or enteral nutrition. Want to watch out for any fluid overload. And then, of course, other medications. We might do antidysrhythmics if it's irregular heart rhythms, cardiac glycoside or DIG, digoxin. We might do some diuretics, and we might even do some morphine. So nursing management, we want to make sure we do good assessments. Our LOC, vital signs, hemodynamics, urine output, skin color and temperature. Look at our labs, ABG with base deficit or lactate, SVO2 or SCVO2 in our comprehensive metabolic panel. Actions would be oxygenation. We want to look at that. We want to make sure that if they do need some, we're looking at non-rebreather, potentially even mechanically ventilate them. With our IVs, we're always going to start 2 again. So we'll have 2 IVs, large bore. We might do some vasoactive medication administration. A lot of times, if that's the case, and we do vasoactive medications, I'll try to start either a PICC line or a central line for these patients. And then 2, we might look at other medications, diuretics, morphine. We want to try and limit activity to kind of lessen the load of the heart. So some teaching we might do is, depending on what the cause is, instruct the importance of rest periods. If it was an MI, what the causes are, causes of the cardiogenic shock. And then we want to monitor the progress, clinical manifestations, and hemodynamic status. So let's do a connection check. The nurse correlates which of the following hemodynamic parameters to the patient with cardiogenic shock: decreased afterload, increased contractility, increased cardiac output, or increased right atrial pressure. One pause, answer the question, and then when you come back, I'll have the answer. So the answer is B. Cardiogenic shock is caused by decreased contractility, which results in a decreased cardiac output in the face of adequate or increased filling pressures. In an attempt to increase cardiac output and blood pressure, vasoconstriction occurs as a compensatory mechanism, increasing afterload, the SVR, which is a systemic vascular resistance, so it's going to increase that. You'll have right atrial pressure, which will be increased due to the volume excess. Okay. So moving on, we've got obstructive shock. It's caused by a mechanical barrier to ventricular filling, like tamponade or a tension pneumo, or ventricular emptying, like a PE, causing decreased cardiac output. So decreased cardiac output is due to impeding pumping action of the heart. So something is impeding that pumping action, which causes decreased tissue perfusion. So typical manifestations of shock, it's usually because of the result of that decreased cardiac output and impaired peripheral perfusion. Additionally, chest pain and shortness of breath are usually often profound. You might have some muffled heart tones with cardiac tamponade. You might have some signs of right-sided heart failure due to impaired filling. You might have tamponade or right afterload, so if you have a PE. You might also have signs of a tension pneumothorax, which is life-threatening. So it develops when air is trapped in the pleural cavity under positive pressure, displacing mediastinal structures and compromising cardiopulmonary function. So some hemodynamics, you'll see an increased SVR, so increased systemic vascular resistance. You'll have low cardiac output, a low SVO2, which again is a reflection of oxygen consumption at the tissue level. Mainly, we want to treat the cause. So if it's tamponade, we're going to do a pericardiocentesis. If it's a tension pneumo, we're going to do a thoracentesis. If it's a PE, we might do thrombolytics or a thrombectomy. We want to provide oxygen as needed. 100% non-rebreather, they may also need mechanical ventilation. We might do some vasoactive medications such as norepinephrine and dopamine. Remember, vasoactive medications produce vasoconstriction, increasing blood pressure and allowing the patient to stabilize until definitive treatment is implemented. And then we'll do slow progress again with our parenteral or enteral nutrition. Nursing management, very similar to the others. So we'll do assessments, LOC, vital signs, hemodynamics, urine output, skin color and temperature, all of our labs, ABG, SVO2, or SCVO2. We're going to make sure we apply oxygen as needed. We'll do vasoactive drips, a heparin drip for a PE, or even thrombolytics for a PE. And then we'll try and prep for the treatment of what the cause is. So are we going to do pericardiocentesis, a suction thrombectomy? So for teaching, we'll want to teach prevention of a PE or DVT if that's a cause, mobilization, fluids. We'll want to do maybe some anticoagulant teaching if that's the cause, such as labs, electric razors, soft toothbrush, about vitamin K. And then we would just want to monitor the progress. All right, distributive shock. So it's caused by disease states that cause poor vascular tone and vasodilation, resulting in increased vascular capacity and venous pooling. So we have widespread vasodilation causing the decreased systemic venous return, resulting in vascular pooling. So the blood volume doesn't change, but you'll have relative hypovolemia because of that decreased venous return. So there's three types. We'll have either neurogenic, septic, or anaphylactic. Remember, distributive shock is either neurogenic, septic, or anaphylactic. So neurogenic shock, it's caused by a disruption of the sympathetic nervous system, typically as a result of a spinal cord injury. Could even be a regional spinal anesthesia or an injury to the brain. So it can be parasympathetic or overstimulation, or sympathetic, which is understimulation. Consider your spinal cord injuries or traumatic brain injuries and head injuries. So some manifestations. Initially, it's related to this sort of rest and digest response from the brain, needing our nervous system to take a break. So that rest and digest will cause hypotension, bradycardia, bradypnea, and flushed skin secondary to vasodilation. The clinical manifestations of neurogenic shock are slightly different from the other forms of shock. Similarities include the patient has decreased cardiac output as a result of this decreased vascular tone and reduced venous return. However, because of the disruption in the sympathetic nervous system, the patient may be bradycardic rather than tachycardic. Remember that. Hemodynamics, so cardiac output, central venous pressures, and our PaOP are low due to decreased venous return. Systemic vascular resistance is low, secondary to systemic vasodilation. Medical management, so we want to treat the injury depending on what it is. Again, oxygenation is our priority. We might do some vasoactive medications, phenylephrine, epinephrine, dopamine. We might do midodrine. It's used to treat orthostatic hypotension. It's in a class of medications called alpha-adrenergic agonists. It works by causing blood vessels to tighten, which increases blood pressure. We also want to do careful fluid resuscitation to increase vascular volume to match the increases in the size of the vascular space due to that massive dilation. And then too, if bradycardia is severe, we might do a little atropine or pacing of the heart if it's severe. For nursing management, we're going to do the same assessments as all the other shocks. So LOC, vital signs, hemodynamics, urine output, skin color and temperature. Look at our labs, our ABG, base excess, lactate, SVO2 or FCVO2. And then actions are similar. So oxygen, we might do non-rebreather or an ET tube. Cautious with IV fluid resuscitation though. Vasoactive drips. We might do a little atropine or pacing for bradycardia. We want to make sure the head of the bed, we move up slowly, secondary to any orthostasis, and then we'll do some SCDs on these patients. So what's some teaching that we'll do for these patients? If it's a spinal cord injury, we'll do spinal cord injury teaching, mobility, complications, etc. And then for outcomes, we really want to monitor the progress. So prompt recognition and treatment of neurogenic shock is essential. We want to stabilize blood pressure, heart rate within normal limits, and adequate cardiac output are signs of successful intervention, which really those outcomes are essential for all of the types of shock. Okay, so let's do another connection check. Which are manifestations of neurogenic shock? Select all that apply. You can pause, answer, and then I will turn the next slide for the correct answers for you. All right, so the answers are D and E. So neurogenic shock is caused by that vasodilation, resulting in decreased venous return and right arterial pressure. So neurogenic shock is seen in severe brain or spinal cord injuries. So these causes lead to increased cardiac output via increased heart rate, or SV, in response to tissue hypoperfusion from extreme vasodilation and increased permeability, which is our low systemic vascular resistance. Due to the loss of the sympathetic response, bradycardia occurs. Respiratory rate might be low due to the injury, causing neurogenic shock, especially if it's like a cervical spinal cord injury. Anaphylactic shock. So this is systemic hypersensitivity. It's a reaction that's caused usually by an allergic reaction, leading to histamine being released with widespread venous dilation or hypotension. You'll have increased capillary permeability, so they will have some edema, and then also smooth muscle contraction, which we have usually airway issues too. Manifestations are related to the overreaction of the immune response. Some are worse than others. Usually we'll have some airway compromise and circulatory problems, so they might have tachypnea, some wheezing, stridor, cyanosis, urticaria, itching. You might have some confusion too due to hypoxia, especially if it's left untreated, and then it would go into respiratory arrest. You'll see a sudden onset and rapid progression of skin or mucosal changes. And then, of course, other manifestations will relate to the shock stage and how severe. So hemodynamics include hypotension, tachycardia, decreased cardiac output, decreased filling pressures, and decreased systemic vascular resistance. Medical management, 100% non-rebreather oxygen. We might even do mechanical ventilation. Airway is the priority. We want to remove the trigger. We'll do some IV fluids. Usually we'll do epinephrine IM. It's the immediate first treatment priority and the preferred route because it provides a consistent rapid rise in the therapeutic concentration and lowers the risk of cardiovascular complications that can be seen with IV epinephrine. You can repeat the dose 2 to 3 times. Most patients will respond to the IM epinephrine. If not, then you can administer it IV. So epinephrine does promote bronchodilation. It does relieve respiratory distress and does cause vasoconstriction to aid in restoring the blood pressure. We'll probably do some corticosteroids, antihistamines, and maybe some inhaled bronchodilators, which is that SABA, which is short-acting beta agonists. They're just also additional medications that can be utilized to treat anaphylaxis. So nursing management, we're going to look at our LOC. Vital signs are hemodynamics. So we're looking at hypotension and decreased filling pressures that are present because of that widespread vasodilation that results in decreased venous return and cardiac output. You'll have tachycardia that results as a compensatory mechanism. Urine output, skin color, and temperature. We'll look at our labs again, ABG with base deficit, lactate, SVO2 or SCVO2. A CBC with differential, we'll do that because we want to look at the eosinophils and see if they're elevated for an allergic reaction. Actions, oxygen, of course. We might do non-rebreather or ET tube. Remove the triggers. We'll give IV fluids, give them IV epinephrine or IM epinephrine, and then other medications too, like our antihistamines, corticosteroids, or short-acting beta agonists. We'll want to do some teaching with these patients, especially about avoiding the trigger, and then also, if prescribed, we'll teach them how to use an EpiPen, and then also teach them how to do bronchodilators if that's prescribed. We want to monitor the progress of these patients. So successful treatment is demonstrated by stable hemodynamics. We'll have the resolution of airway compromise, evidenced by a resolution of wheezing and shortness of breath, so they'll be able to breathe normally, and resolution of skin reactions, itching, and swelling. So continuing with the case study, this is episode 2, so same patient as before. So Mike's condition deteriorates while in the ED. Initially, he was alert and oriented times 4. Now he's confused and lethargic. He's admitted to the intermediate care unit. Vital signs are 80/50. Looks like his blood pressure dropped a little bit. Heart rate's 130. That's gone up. His blood glucose level is 220. Remember, no history of diabetes. Flush with bounding pulses. Temperature 102.6. 39.2. His SpO2 is 90% with 100% on the breather. That's not good. Bolus with 2 liters of normal saline. We've inserted a Foley catheter for strict Ivanose, and then we continued IV antibiotics. So, progressing, not doing so well. So, looking at what we're seeing in that case study is kind of going into this next part of our lecture into sepsis and septic shock. So you will see this very, very often as a nurse. So sepsis is a life-threatening organ dysfunction caused by a deregulated host response to the infection or an infection. You might see what's called SIRS, which is a systemic inflammatory response syndrome with a documented infection. So septic shock occurs when circulatory and metabolic abnormalities are profound, greatly increasing mortality. So septic shock is a shock state due to sepsis, to that infection. There's increasing incidence, of course, we're seeing this very often. I think hospitals too are getting more aggressive in treatment and identifying sepsis. There's definitely a high mortality rate of 20 to 50%. Septicemia, you might have heard this before, is an infection in the blood, is evidenced on blood cultures, results in an inflammatory cascade. So septicemia causes sepsis, causes this SIRS or SIRS, which is systemic inflammatory response syndrome with a documented infection. You'll see SIRS a lot in some of the physician's documentation when you start looking at H&P and doctor's notes. So septic shock develops, and then further complications can develop, such as disseminated intravascular coagulation, or DIC, or even multi-organ dysfunction syndrome, which is MODS, your MODS. You'll also want to look at figure 14.7 on page 276. This is an algorithm to guide the identification of sepsis and septic shock. It's an assessment tool indicating the presence of sepsis. The SOFA score can be used to determine the level of organ dysfunction and mortality risk, and this is especially utilized in ICU patients. So SOFA, or SOFA score, sequential organ failure assessment, is a mortality prediction score. It's based on the degree of dysfunction of 6 organ systems, usually used in the ICU. So it's calculated on admission, and then they do this every 24 hours. They'll recalculate until discharge using the worst parameters measured during the prior 24 hours. So the scores can be used in a number of ways, as individual scores for each organ to determine progression of organ dysfunction, as the sum of scores on one single ICU day, as the sum of the worst scores during the ICU stay. It is believed to provide a better stratification of the mortality risk in ICU patients, given that the data used to calculate the score is not restricted to admission values. So, figure 14.7 on page 276 looks like this. It's an algorithm to guide the identification of sepsis and septic shock. So this is something that they would use in the hospital system. You also might see these little badges on some of the nurses' badges. So it's kind of a badge shortcut to help with sepsis identification among the nurses there. I think that I'd say within the last maybe 10 years, sepsis has become much more of an issue and more identifiable, and more, I guess, nurses are becoming more aware of how important it is to effectively treat these patients as early as possible and make sure that we do very thorough assessments, and then identify any changes and monitor trends on our patients. So I'm going to go ahead and take a little break here and then stop this recording, and then when you're ready, you can go ahead and start the second recording to our shock lecture.